So I think we're going to go ahead and get started for the next session. It's funny when everyone wants to come back and take their seats. I'm going to be the kicking off of a series of TED Talks, which 10-minute talks for the next few speakers. So the pieces that I'm going to actually talk about is something that almost every single person has actually spoke about this morning. And really, what is that value proposition of doing this? And what is the impact of this in that value proposition? I think we heard earlier this morning that budgets are tight, hospitals are struggling. I think we've already asked, what's the budget to do the research? What's the budget to do the pieces? So I'm going to start to talk about a little bit what this system gives us, and how do we start to justify some of those advancements that we have, because it's not always obvious as we look through the bigger pieces of the system. So when you start to look at the value proposition for SaAMS, let's first, before we do that, let's talk a little bit about the system and the environment that you're actually going into to do this, the environment, as we go through and look at this. So when you're at the bedside, if you're a medical device, if you're a provider, even if you're the patient, you're part of a system of systems. Currently, that has been a system of systems that has been loosely designed, ad hoc designed, or at least a series of siloed systems that really don't talk or integrate to each other, where that main system is actually the care providers are having to be the integrator on the fly as they walk through and do these pieces. But what is at that bedside? What's created in that system if we had that ideal integrated system of systems around the patient bedside? And what you have is high fidelity data. There's about 500 data points being collected for any given patient at any time in an ICU. Those data points range from clinical observations that are done by the clinicians, data coming from medical devices, data about the devices themselves, data about what room they're in, the location they're in, what procedures are being given. And so when you start to actually look at this large data set, that data set is actually telling you what's happening with that patient at that given instance in time. This is actually a very rich data set that you need to look at and to do this. But the other thing is that data set is what's being used for many of the existing autonomous systems as they go through and look at it in a smaller segmented set, in a smaller piece of data. But I think we have to think about and start to imagine what happens if you had access to the entire set of data? What happens if every algorithm had access to not only time synchronized clinical observations, but device data, potentially historical data, and you could bring that data and that information together to actually be able to use that as a system. So that actually provides you not only benefits clinically and operationally, because it starts to give you real-time acknowledgement of what's going on, but it also starts to provide you a lot richer data set to do risk management. And a lot richer data set to do information about that set of risk management. So what we're finding and what we're seeing is when we start to look at this value proposition is the more data, the more value proposition we actually have, and the more things we can actually do from a risk management standpoint. So I would say that this is probably a rare occasion that these things are starting to become aligned, not only from the financial side, but also the clinical side, to be able to actually advance clinical care, but actually show improvements because of this data that's being collected at the bedside. The bedside data, if you think about it, is the source of all healthcare data. Everything that you collect, that you see in a medical record system, you see in a billing system, comes from that patient and the interactions that occur with that patient, not only during clinical care, but preclinical care. So when you start to get to this, you're at the foundation of all the sources of data. Everything after this is a data transformation. So this is something to think about as we look at this. And this ecosystem, that everyone who comes to the ecosystem needs to become a good actor in this ecosystem, because they're a contributor and a consumer of this information and this data as it goes forward. This actually makes things easier for everybody. And we have to start to engineer this ecosystem. It's not engineered right now. I can say that from very much experience. We need to understand how these devices interact with each other. We need to understand the interactions of the pieces. We need to understand what data needs to be visualized and where it needs to be visualized at. The next thing that brings up to this is security. Having an ecosystem like this, having a platform approach to be able to do that ecosystem, actually takes the pressure off every single player in the ecosystem to have to solve all of their own problems, that they should be able to leverage the ecosystem and the infrastructure to be able to actually risk manage their system, increase security, get better data, have a better understanding of what's going on. It actually makes things easier across the board for everyone to understand that. It does add additional complexity in risk management because multiple things can be occurring at the same time, but honestly, it's already occurring simultaneously with each other anyway. So you're already in the ecosystem. It's about us becoming good actors in this ecosystem to move this forward. The last piece of this is another area of this resiliency that actually that becomes interesting is the operational resiliency that comes from this. Once you have this layered approach to be able to do this, you start to actually be able to maintain operations during certain events. You have better data, you have real-time data, not for clinical purposes, but you can use this data for hospital operational purposes, for home operational purposes, on the military aspect, command and control type decision-making that can occur. So when you start to look through this, these all align with each other because these are the same things that are required that we're talking about in this SaAMS community and with the collaborative community, that we need these things for risk management anyway. This is one of the rare times I think we've started to have this conversation where these two things weren't actually opposed to each other. And then what's the justification for doing this? Why do we need to do this? What does this need to look like? So the last piece of this I have is I actually laid this out now. What's the benefit to all the actors in the system? And the actors in the system, you know, the patient's going to get safer healthcare. They're going to have a better understanding. And just to be flat out, they may not have to be asked the same question 400 times while they're sitting at the bedside. Because the data is going to be available to them at the time that they needed and the location that they need it in and where it's actually going to be looking and being to be available. The clinicians, you're going to get automation, and automation isn't some of the things that that we've talked about in this room of closed loop anesthesia and other things. You're even getting automation in documentation. You're getting automation in the fact that if you need someone, telemedicine is embedded into the system as you look at it. I think we have to expand what our thinking is that closed loop systems, autonomous systems are part of this ecosystem, but these other capabilities that come available when we have this layer or this level of interoperability actually makes everything else a little bit easier also in the fact that you can use telemedicine as part of your risk management protocol. If you had someone on call that you're running an autonomous system and it automatically made a telemedicine call, you're risk managing that because now a clinician's available. You don't have to wait for someone to come to the bedside. So as you move through this and you look at this, creating this system of systems, this hasn't been done in this part of the clinical environment. We have very sophisticated IT infrastructure in hospitals. We have some hospitals have somewhat sophisticated cyber guidelines, but not everyone. But this actually helps start to build that layers and that approach and starts to allow us to engineer those pieces of the system as it goes forward. So I am going to just pause there. I think that's the biggest piece of this. And I will go on to the next one. But thank you guys so much. And thank you guys for everyone for coming today.